Clinheim, Hematology, Demystified.
Okay, so welcome again. Today we're trying to go through bone marrow failure syndromes, both acquired and inherited, and featuring PNH because PNH goes with the bone marrow failure syndromes, as you know. Um, and the layout is we will start with some misnomers because I know some of you are quite senior, but some of you are starting fresh, like we all were at one point, and some of the terms will confuse you. So I'll just try to clarify them. Then we will jump straight into bone marrow failure syndrome, starting with the case and discussion. This time I thought maybe it's a good idea to get a bit more interaction and get the pathway out of you if you guys are keen. Otherwise, of course, I will jump in and then take it from there. And then we will discuss the bone marrow failures in details, introduction, what is aplastic anemia, what is the pathogenesis of bone marrow failure syndrome, briefly, clinical features, diagnostic self-treatment, and then PNH similar pathways, starting with a case if we have time and you have energy, and pathogenesis and treatment. So misnomers. So do you think this is a misnomer or not? Aplastic anemia. So when we say aplastic anemia, do you think this actually means what it says or no?
Because it mentioned anemia, it is not only anemia, it's actually pancytopenia.
Exactly. So this is something that the uh, the ones who are at junior stage probably get confused about. But yeah, it should be called aplastic pancytopenia, but maybe that's how it was diagnosed. First of all, the patient had anemia or whatever. But yeah, it is aplastic pancytopenia. But when we say anemia, aplastic anemia, we're actually not just saying the person can't be thrombocytopenic or leukopenic, of course. But most of you already knew that. That's good. Thank you, Amani. Is this a misnomer? Paroxysmal, nocturnal, and hemoglobinuria. If this is a misnomer, what's a misnomer or what's not a misnomer?
The haemolysis isn't only happening at night.
Yes, exactly. It's not paroxysmal, it's happening all the time. It's not nocturnal only, but the urine color is darkest in the morning because person is dehydrated, etc. Um, so the first two bits are not true, but that's how they've been, they were described, and that's how the name is, it's just been stuck. And hemoglobinuria is, of course, true. Good. Is this a misnomer? Rackpan diamond syndrome? Or anything wrong here? No? It's supposed to be Schwackman diamond syndrome, but as I'll explain later, you will remember this as Schwackpan because pancreatic insufficiency, PAN, is the diagnostic feature that you will identify for this syndrome in exam. So I will call it Schwackman diamond syndrome for now. Base Schwackman, of course. Okay.
Isn't it
Yeah.
is Schwackman or Ban?
Is man, but that's what I'm saying. So Schwack, I like to call it Schwack Pan because PAN helps me remember pancreas. So the problem is one of the main diagnostic clues is the person would have pancreatitis, chronic pancreatitis. But you're right, it is Schwack-Man diamond syndrome, not Schwack-Pan diamond syndrome. Anyhow, good. So starting with this case, a 19-year-old female develops 7 weeks of increased bruising and fatigue. A blood test is done routinely, and the lab gives you a ring. The patient is sat, say, in your assessment unit. Um, they're very neutropenic, very anemic, and so really thrombocytopenic. So we will try to be quick with it, but if you can tell me how will you proceed with this? So what would you do? The patient sat next to you, and these are the results. Or maybe actually, no, you've got time to do a bit more of investigations, and whatever you say, you will get the results there and then from me. So what would you do? The lab is on the phone with you, or you want to call the lab or whatever. So what's the next step?
Blood film and reticulocyte count.
Very good. So the blood film does not show anything abnormal, maybe a little bit of macrocytosis. But surprisingly, there's no polychromasia in there, so inappropriately low, and the reticulocyte count is low as well, so inappropriately low reticulocyte count. But there is no abnormal cells in there, no blasts, no teardrops, no LGLs or whatever.
That
That
LDH,
that is negative, LDH normal,
haptoglobin,
haptoglobin is normal. So you've done a
urine. Yeah,
urine's normal as well, as in doesn't show anything. If you're looking for hemoglobin or red cells, doesn't show anything. Yeah, it's fine.
yeah.
No,
And then I would go back to the history, drug history.
no new drugs. Yeah,
No.
she's been feeling like that for several weeks, and she just thought she's so tired and bruised, so she might as well get a blood test done. And this is where we are.
Hematics.
Normal. Very
Yeah,
good. So
examination for lymphadenopathy, organomegaly.
nothing found there on examination. So no organomegaly or hepatosplenomegaly.
Then I'll proceed for bone marrow.
Sorry, you do bone marrow. Yeah, that's good. Mhm.
Would suggest doing a virology screen as well, including
Yeah,
the
very good.
Yeah, I was going to add
hepatitis
that.
B, C, HIV, parvovirus, CMV,
Yeah,
EBV.
perfect. Everything's normal. We've got a very quick lab. We're living in 2090 or something. So everything's come back instantaneously. Finger prick test, everything's normal that you've said. But yeah, that needs to be sent. Yep.
And
And
immune globulins as well.
they're normal as well. Good. Yeah, that's all sounds good. Okay, we'll do a thyroid screen. We'll do an autoimmune screen or whatever as well, but that's fine.
Hemoglobinopathy screen,
Yeah, that's good. Very good as
hemoglobin F
well.
level.
So F level, very good. So they
Yeah.
also come back as normal for her. So that's good. Yeah, great. So as you know, HbF levels, as we will discuss, they can be raised in some constitutional or inherited causes of bone marrow failure syndromes. Gives us a clue. Okay, so everything's normal from the blood worker point of view. Bone marrow will be done. Somebody's preparing equipment for you. You work in a posh hospital. Anything else you would like to do, or good? Shall we tell you the bone marrow results?
Yeah, bone marrow also scans like CT tab just to
Yeah.
complete.
CT tab, only I would say she's young. So if you're finding anything, then yes, we should definitely consider that. But otherwise, maybe just a chest X-ray and an ultrasound abdomen would do as well, because you don't want to expose her to too much radiation. But yeah, of course, if you're suspecting something like that would only be picked up on a CT, say you're suspecting lung fibrosis on your exam, or suspecting other congenital anomalies that you have seen, but you haven't seen in her. But if you had seen, then you would do more detailed imaging. Very good. So yeah, bone marrow, as you know, you've done it, but you can look at it in the hospital. So you've done it. You made slides. Everything's ready there for you. So what would you look at? So you've taken a aspirate and a trefine as you normally do. You've taken cytogenetics as well. Slides are ready. What would you suspect to see in aspirate and what you wouldn't suspect to see in the aspirate?
We'll check cellularity.
Sorry?
Cellularity.
Cellularity, yeah. So cellularity, as you know, is best assessed by trefine, but you can get a little bit of idea from aspirate. So from aspirate, unless you've started looking at bone marrows already, so by aspirate, you can see the particles. You've taken a very good sample. You're very good at bone marrow. So you've taken a very particulate sample, and the particles look empty. So there isn't a lot of cells there. The trails also don't look very cellular either. But as I say, cellularity is assessed officially by trefine. And what else? So this is the cellularity. So on the aspirate, you have seen the cellularity. What else are you going to see now? Look for on. Yeah, so you're going to start looking at the lineages now. Let's pick a lineage. So did you say red cell? That's fine. So dysplasia is present. So there's a little bit of this erythropoiesis present there. And what else would you look for in red cells?
Blast.
Yeah,
We will also look for blood. Oh,
yeah,
sorry,
we will.
dysplasia. Okay.
Right. So red cells, of course, for all the lineages that you need to look at, you look at their number and how they look like. They don't look normal, so there is this erythropoiesis, but the number of erythroid precursors is low. Yeah. When we're coming to the white cells, for example, so there is granulocytic maturation, so there is a mature neutrophils that you see, but they are also low. So low in number, but no dysplasia in the granulocytic lineage. The ones that are present, they look normal. And there's no left shift, so there's no excess of blasts. So they're clearly less than 2% or whatever. You've done a very good differential, very good at it. So you've done the red cells, you've done the white cells. So both show low number, but in red cells, there is this erythropoiesis. In white cells, there isn't any dysplasia, but just the number is low. And there's no blast or anything like that. Lymphocytes, they look a bit more prominent. So wherever you see that, you just see lymphocytes. Why is that? We'll discuss that later, actually. So the lymphocytes do appear prominent, but they don't look, because relatively they look prominent. There's nothing else to see. They're just lymphocytes there. Okay, so last, the megakaryocytic lineage, which most people try to look for at the beginning, but that's fine. We would done it at the last as long as we do them. So similarly, number looks low, but there is no, they don't look abnormal. Okay. Anything else?
In the red blood cell, do we find erythroblast?
Erythroblast, no, increased. No, you wouldn't see them, but you would see this erythropoiesis in there. You can see this erythropoiesis in aplastic anemia, which no surprise this lady has got, because this is what we're discussing. Okay, so you've done aspirate. Anything else in the aspirate that you have missed that you want to see? You don't see any abnormal cells otherwise. So lastly, what you see, you scan for any abnormal cells, any abnormal lymphocytes, any abnormal blasts, or anything like that. So basically, and then trephine is presented to you. So what do you see in a trephine now, systematically? So what do you start first?
Articulation and cellularity?
Yeah, very good. So cellularity is very low. So it's less than 25%. You live in 2090, so you've got AI helping you with that, and this AI never fails. So the cellularity is very low. It's maybe 10% or something, very, very low cellularity. And you don't see any abnormal precursors. All the three lineages, as far as you can see, they're okay. There is no fibrosis there, which is important to rule out.
Any abnormal cells that indicate
Nothing.
metastatic bone disease, like
Yeah.
Ewing sarcoma?
Very good, yeah. So you don't see anything. So aplastic anemia is really good because it makes you think about all the causes for pancytopenia, because this is a diagnosis of exclusion, so to say. You think about everything, and there isn't anything there. So what's the diagnosis looking like so far? Clearly, what is the diagnosis? Anybody want to say?
Looks like a bone marrow failure syndrome.
Very good. And if this is aplastic anemia, this is severe aplastic anemia, of course. Yes. So now, what do you cytogenetics? So what do you see in
Sorry,
cytogenetics?
how do we say severe? Because we don't have reticulocyte count, or if
I
you mentioned them.
I gave them in the beginning.
It was there already. Sorry,
Yeah,
I was
yeah. I mean, I verbally gave it to them. Yeah. Okay. Now, and we'll come to the severity and things. Of course, I won't just finish here. We'll explain what it means. Okay, so yeah, you sent off cytogenetics. Karyotyping does not fail for some reason, which is surprising. So that's normal. Maybe actually you just see deletion of 13q in there, but nothing else. And then you also see the genetic panel that doesn't show anything suspicious. So this is very suspicious. This is basically you ruled out anything else, any other malignant process, fibrosis. You don't see any abnormal lymphocytes or clonal lymphocytes anywhere. So basically, you made a diagnosis of bone marrow failure syndrome, specifically, most likely aplastic anemia. He hasn't got any suggestion to say that this is inconstitutional from her history examination. And this, basically a history examination and any other investigations that you did.
It
So,
could be Evans syndrome.
which one, sorry?
Evans.
Evans would give you hemolysis, of course, but we don't have any hemolysis. That is
Okay.
negative. Bone marrow doesn't support that. The only thing you've seen is a little bit of dyserythropoiesis, clearly very hypocellular. So in hemolysis, you can see compensated, expanded erythropoiesis and stuff like that. Basically, this is what it looks like. So you would, if you did suspect from the history, you would do, panels for some testing and some panels through inherited bone marrow failure syndrome. So that's how you do. And you will notice that what I'm going to discuss in the next few slides, you've covered everything. Yeah, Thea is still on the same. Yeah, it's still on the same one. Yeah, intentionally so. So yeah, so that's where you are. So you basically, aplastic anemia is a diagnosis of exclusion. You will exclude everything else. And once you've diagnosed this is aplasia, you want to see if this is inherited or acquired. And you have thought this is acquired. And the last step would be to find out an abnormal clone. You've done cytogenetics, there is no abnormal clone there. So abnormal clone can be of a few types. It could be abnormal malignant clone suggesting, or if this is MDS or hypocellular MDS or evolving into MDS, or it could be PNH. So there, these two abnormal clones you have to exclude as well. You have done a PNH screen that's negative as well. So this is just severe aplastic anemia, most likely acquired. That's how you would investigate anybody in the clinic anyway as well. And we will discuss these things in a bit more detail. So what's bone marrow failure syndrome? It's, as the name suggests, like any other organ failure, this is bone marrow organ failure. But the problem here is that disrupted. We specifically say when the problem is with the hematopoietic stem cell and progenitor cells disruption, so with the homeostasis and function, and as a result, it results in cytopenias. There's a significant interplay between environmental, genetic, and immune factors that actually brings about this problem, which we will try to discuss as we go along. When we say aplastic anemia, which I said is a misnomer, we should say aplastic pancytopenia. It's pancytopenia with a hypocellular bone marrow in the absence of any abnormal infiltrate or marrow fibrosis, and you have to have at least two of the following to even think about doing suspecting aplastic anemia. That's like strict textbook definition, which is you have to have anemia as in I have to have two of the cytopenia. So anemia, hemoglobin less than 100, platelets less than 50, or low neutrophil count. So you have pancytopenia within hypocellular bone marrow in the absence of any infiltrate or marrow fibrosis, and you have to have two cytopenias. Now, this is how hypocellular bone marrow looks like, which I'm sure you already know. But it's not part 2, so we won't dwell on it. How do you grade the severity? So severe is when the marrow cellularity is very low, which is less than 1/4, 25%, or if it's between 25 to 50%, the hematopoietic stem cells are less than 30%. And you have to show that this hypocellularity is actually translating into cytopenias as well. So you have to have two severe cytopenias as well. It's not difficult to remember for anybody who's worked at least 1 year in hematology what we mean by severe cytopenia. So as you know, neutrophils, when we say severe, we think of less than 0.5. Platelets, we think of less than 20. And reticulocyte count is actually, we don't, but less than 60 with automatic analyzers. So as you see, for cellularity, you use neutrophils, which is obvious, platelets, which is obvious, but instead of red cells, you use reticulocyte count because that's actually a good measure of how much your red cells are being produced instead of hemoglobin, because that can be from different, altered from different factors, etc. That's why we use reticulocyte count, which is good. This is severe. So marrow cellularity less than 25% or between 25 to 50% with less than 30% cellularity and two severe cytopenias. And it's very severe if all of the above, but neutrophils are less than 0.2. And it's non-severe when it's aplastic anemia, but doesn't meet the criteria for severe or very severe. And it's important to know all of this. They will ask you, when they say diagnose it, they will give you enough information to help you diagnose aplastic anemia, but you have to say what severity, because treatment, as you would see, depends on how severe the aplastic anemia is. treatment options are different. Briefly about epidemiology. So 80% of the cases are idiopathic, 20% are from inherited. The ratio can be reversed in exams. So in exams, it feels like 80% are inherited, but anyhow, bimodal peaks, one in youth and one in old. And remember that inherited bone marrow failure syndromes can appear in young and even mid-adulthood, so not restricted to childhood. The acquired version is more common in East Asia. Overall, it's the rarest cause of pancytopenia is aplastic anemia, by the way. But anyhow, it's a very important cause to diagnose though, because it's equally bad prognosis than say any hematological malignancy, as you know. So this is a heavy slide, but I try to break it down, the causes of bone marrow failures, because this can be easily a long essay question, and it can easily ask you the causes for bone marrow failure. So there can be inherited causes or acquired causes. Inherited in terms of those disorders that predominantly cause monocytopenias. So anemia, as you remember from last week, Diamond-Blackfan anemia, DBA, in which red cells are like diamonds, precursors are like diamonds, so they're not found. Pure red cell aplasia is there. And ADA, so ADA is raised in DBA, as you would remember. And congenital dyserythropoietic anemia. So both of these we discussed last time. Thrombocytopenia can be from these two conditions, which I will send you separate stuff about because they can be asked in MCQs and they have been. So congenital megakaryocytic thrombocytopenia, problem with the CMPL mutation, with the mutation CMPL, and megakaryocytic thrombocytopenia with absent red eyes. They really like the second one in MCQs for some reason. And then neutropenia, severe congenital neutropenia, as you know, easy name to remember. Coming to bitricytopenias, so this is where we will spend a bit of time in the top three. So Fanconi anemia, short telomere syndromes, especially DC, dyskeratosis congenita, and Shwachman-Diamond syndrome. And MDS, you can have inherited MDS, and you can have, of course, from other problems like Down syndrome and Pearson's as well, which is which actually gives you sideroblastic anemia and some pancreatic insufficiency as well, along with mitochondrial pathway problems, mitochondriopathy. Very rare, and people die under 5 without transplant and stuff, and for the care for pancreatic illness, but very commonly asked in exams, and you will be tested on that in week 7 on MCQs. Anyway, acquired, relatively easy to remember, like as any other autoimmune condition. So ITP or hemolysis can be primary or idiopathic, which is most common because we don't find a cause, and that's a primary or idiopathic aplastic anemia. It could be secondary to anything, and the list as is you will it's the same as any other autoimmune infections, usually viral. There's a specific syndrome called post-hepatitic aplastic anemia. So a person would have a history of having a hepatitis-like illness, maybe LFTs are up, nausea, vomiting, diarrhea. LFTs might still be up now, but they would definitely be up a few weeks ago when they had the illness. Or when you check them for all the known hepatitis viruses, they would be negative. This is quite IST responsive, so good to diagnose. Can be from other viruses. Autoimmune, any condition can give. SLE can give, is very rare. I've seen it once in my life. Any other can potentially give you aplastic anemia. Sometimes a clonal proliferation of cytotoxic CD8 on their own or as part of LGL can cause pancytopenias. And drugs are very important to remember and mention, not only for real life, not only for exam, but also for real life. Of course, there can be chemotherapy drugs are going to give you aplasia, which is really transient, but there can be some idiosyncratic reactions with other drugs like anti-epileptic drugs. Radiation is important to ask in the exam as well as in real life. Have you ever had any radiation for anything? And transfusion-associated graft-versus-host disease can really cause it as well. So this is a list. It will help if you try to remember this for the exam and for real life. I will just make some observations. So see diamonds, they are diamond in this name, diamond in this name. I don't know if they're the same person, but just two observations. So both actually have ribosomal problems. Diamond-Blackfan anemia, if you remember, is a ribosomal problem. Shortman-Diamond syndrome is also a ribosomal problem. And both of them actually, the single lineage problem, at least initially. So Diamond-Blackfan anemia is pure red cell aplasia. And in Shortman-Diamond syndrome, actually, you get Shortman-Diamond syndrome, you get neutropenia usually initially, and then it progresses to pancytopenia. So, and DBA can very rarely go to pancytopenia as well, but this is the predominant cytopenia classification. So that was something I observed, which is hopefully helps you remember a bit. And moving on to boring or interesting, depends how you like things. What is a stem cell? Anybody can give me what you think what a stem cell is? That is a cell with two properties at least. So,
One is
CD34.
regenerate.
sorry, what the CD34. I'm not asking for a marker, Ramani. I'm just asking what is a
I
stem
think
cell?
one is the capability to regenerate, and one is the capability to divide into different cell lines.
Exactly. A cell with two qualities, totipotency or multipotency. So if it's totipotent, it means it can give rise to all the cells of the tissue, and multipotent, it can give rise to many cells of the tissue. But it has to self-renew by asymmetric division. And there's a role of telomeres, which I mentioned, but before that, I just want to show you this picture. So whenever stem cells divide, one of the cells in the division is actually a copy of itself. This is to keep a pool of themselves. So that's what a stem cell is. And the other cell would become committed to a certain lineage or whatever. But the problem is that each time a cell divides, you might remember from medical school that each time a cell divides, the center of the chromosome is called centromere. The ends are called telomeres. Each time it divides, the end shortens. And if the end shortens to a critical length, it reaches the essential material that is required. So basically, if the end shorten too much, it will reach a stage that the cell will stop dividing, and that is a natural process of cellular aging in many of the cells. But with bone marrow stem cells, they have got this enzyme, and like with some other cells, which is called telomerases. So with each cycle, they will actually elongate the telomere so that the telomere shortening doesn't happen. And this is to help them continue to replicate, because the amount of time stem cells divide, if it was without the telomeres, then they can't divide so many times, and you would see that they will get aged or old and they will stop dividing. And this, no surprise, happens in telomeropathies or short telomere syndromes like DC, which we will discuss, that they have problem with telomerases or other aspects of this pathway, and they cannot they cannot lengthen their telomeres, and after much less divisions, it just stops prematurely. They stop differentiating. That is where the problem lies in them. I hope that's clear. Just to remember. Yeah, so telomerases have two components, TERT and TERC. It's good to remember because these are the problems, and the genes encoding these two domains are problematic in DC. So TE is telomere, RC is the RNA component, and RT is the reverse transcriptase component. So how it does it is that it first provides an RNA template, which is TERC, and on that, using its reverse transcriptase capability, it makes DNA from RNA. That's why it's called reverse transcriptase. So this got two components, which is important to know because DC will have problem in either one of them or both. Briefly, hematopoiesis, you will see this slide in many of our sessions. So pluripotent stem cell gives rise to myeloid stem cell and lymphoid stem cell. Lymphoid stem cell becomes one of the three lymphoid cells. It's a very simplified version, of course. Myeloid stem cell will ultimately give you platelets, red cells, granulocytes, monocytes, which become macrophage in the tissue. So the pathogenesis in congenital is that the stem cells will intrinsically be a problem. So either a telomeropathy or just a problem with their chromosome repair or problem with their ribosomal, functioning, because ribosomes are very important in protein synthesis, etc., etc. But because this would be like a germline problem, not only hematopoietic stem cells are affected, other cells are affected of the body as well. That's why you will see skeletal problems, organ impairments, etc. So that's what happens in congenital bone marrow failure syndromes. In acquired, what we think, this is very complicated, but just to simplify it and for the purpose of the talk, if what we think is T cells develop an immune response, maybe against this myeloid stem cell progenitor, maybe somewhat against the pluripotent as well, but predominantly against the myeloid stem cell. That's probably why you see that the myeloid lineage is all low in the, you have low neutrophils, low red cell, low platelets. But when you do a bone marrow or something, or even the peripheral blood, the lymphocyte count appears normal. In bone marrow, you see predominant lymphocytosis, quote unquote, not lymphocytosis, but lymphocytes appear predominant because they're the only cells left there. So that's why it's thought that maybe this is the target. And why do they develop autoimmune reaction against this? As with any autoimmune disease, we really don't know, but it's thought maybe they have a genetic tendency, and then an environmental insult like an infection comes in, which infects the cells, props up a new antigen, which the body thinks is foreign, and so the new antigen on the myeloid stem cell or the pluripotent stem cell, T cells are going to react against and cause an autoimmune reaction. So that is why in acquired, you use ATG, which is, anybody knows what ATG exactly is?
It's anti-thymocyte globulin. Basically, they take lymphocytes from human beings, inject
Yeah.
them into horse or rabbit,
Yeah.
and the horse or rabbit produces antibodies to these lymphocytes. And when we use this in human body, it obviously destroys, as you were saying, the lymphocytes that we think are responsible to cause aplastic anemia.
Exactly. So ATG is basically a mixture of polyclonal mixture of antibodies directed against human T cell antigens. So antibodies would be directed against T cells like 2, 3, 4, or whatever they are. So all of them, these are polyclonal mixtures. So they try to target the T cells. So exactly this is what is done. Take human T cells, give them to a horse or a rabbit. Horse or a rabbit thinks, oh, this is foreign antigens. They will make antibodies, and those antibodies mixtures against the T cells is what we get, and we give it to the patient, and that explains that. Now the patient would think this is foreign, and that explains the reactions against ATG and stuff that you see in real life as well. So that is why ATG works in acquired, and of course it wouldn't work in congenital because that's not the problem there. Very good. So clinical features, very obvious, pancytopenia, including opportunistic infections, which you shouldn't forget because some people present in fungal pneumonias because they've been neutropenic for quite some time. You have to remember there might be any associated previous seeding illness like viral illness, as I mentioned. Maybe gives you important clue as well. And if it's inherited bone marrow failure syndrome, then symptoms of the condition. Now, what are the symptoms of the condition? I will explain that in the next few slides. And this is where it gets, we're not exposed to these, and this is the the things that you have to remember for the exam. So this we will just spend a few slides on them. The rest is day-to-day work. You would have seen patients with aplastic anemia, so you'll be more familiar with them. But inherited bone marrow, I mean acquired aplastic anemia, but inherited bone marrow maybe not so much unless you are a pediatrician, which some of you are actually. So Fanconi, short telomere syndromes, and STS are the three most common causes of pancytopenia causing inherited bone marrow failure syndromes. And in summary, Fanconi has got abnormal chromosome repair genes, which can be tested by a test which is called DEB test, which I will explain. Short telomere syndrome, no surprise, no problem with telomeres. And you check the telomere length in the lymphocyte, a peripheral lymphocyte or bone marrow lymphocyte. Short-Diamond syndrome, as I said, problem with the ribosome, and usually starts with neutropenia and goes to pancytopenia. And it's shock-pan because you got pancreatitis as well, as I said. So genetics, it's not too difficult to remember. Most of them are autosomal, predominantly so at least, and can be recessive. And mainly, horrible problems are usually autosomal recessive anyway. But anyhow, so Fanconi anemia is predominantly autosomal recessive. They are rare X-linked variants. And genes are not difficult to remember because thankfully they've not named them abnormally. They've named them Fanc A, Fanc B, Fanc C, all the way to Fanc Q. They missed Fanc H for some reason, which I don't understand. But anyhow, they Fanc A to Fanc Q. I think they missed another letter in there as well. And this is more common in, or this shouldn't say question mark, this should be like an arrow upward. So this is more common in Spanish, some ethnicities like Spanish, Romanian, Ashkenazi Jews. So there you have an MCQ point. DC, it would have been easy if they named that with their gene, which they did for X-linked variant, which is dyskeratosis congenita gene 1. TERT gene or Turk gene, which I've mentioned, are the two components of telomere enzymes. And it can happen if other enzymes that are involved with telomere homeostasis as well. But these are the most common ones that they probably will check you on. And SDS is thankfully easy as well. I don't know where the B comes from. SBDS, don't know. But
So it's
SBDS.
basically the two people who found it. This was Shushman and Boudian. So
Oh yeah,
Shushman and Boudian.
yeah,
Yeah.
you're right. Yeah. But SBDS gene is the one. But it's, again, so not difficult to remember, especially with this background, Mr. Boudian as well. Now, going to the pathogenesis. So there's a problem with in Fanconi. There's a problem with Fanconi anemia, FA/BRCA DNA repair pathway. So BRCA, you would remember from breast cancer. These are the same genes, and actually FANCS1, FANCS is BRCA gene 1. It's the same gene, actually, just named. Initially, they thought it was different, and FANCD1 is BRCA2. What happens is that normally you do not, normally a person can form interstrand crosslinks in the DNA, and this is repaired by this pathway in brief. But with this condition, you have a defective pathway that repairs these interstrand crosslinks, and that is why they are quite the chromosomal instability is quite prominent there, and this is especially after sensitivity to DNA cross-linking agents like cyclophosphamide. So how cyclophosphamide works is, you will remember, is it actually induces cross-links between the strands, and then this pathway downstream, this pathway actually activates TP53 and causes cell apoptosis and stuff like that. So cyclophosphamide is exactly working in the way that this pathway is defected in. That's why people are more sensitive to DNA cross-linking agents. Okay, and DC, as I've mentioned previously, is impaired telomere maintenance and premature cells, aging / apoptosis. And Shrockman-Diamond syndrome is, they shouldn't say question mark, we should say arrows. I don't know why it's saying question marks, but anyhow, ribosome biogenesis defects, which impair, lots of different organ functions, but hematopoiesis and exocrine pancreatic function are predominantly affected and of interest to us. All of them would have pancytopenia, and in Shrockman-Diamond, it starts with neutropenia and goes to pancytopenia. And MDS AML risk is present in all of them. So all of them would predispose to hematological malignancies. Fanconi anemia, around 10% present in adulthood. It's important to know. And DC similarly as well can present in adulthood. Shrockman-Diamond usually present in infancy. Yeah. So features, these are the features that you have to look for. 1 second, it's asking me to restart the computer in 2 hours. So yeah, non-heme features, they can be overlapping and they may be absent. So don't just rely on them, especially for real life. In Fanconi anemia, you have these characteristic skin spots, which are pigmentation abnormalities, and skeletal problems, especially with thumb and radius. And you do an ultrasound. One of the things, if you're suspecting Fanconi, is to look for any renal abnormalities. So they can have abnormally placed kidneys or horseshoe-shaped kidneys. And there are some others, sometimes they have cardiac issues as well. Rarely they have those vacteral, VACTERAL problems that you see. DC has got a characteristic triad. So you have nail dystrophy, oral leukoplakia, and abnormal pigmentation. And initially they said this is very mandatory for DC diagnosis, but now there are lots of diagnostic criteria that do give importance to them, but they say diagnosis can be made without them. So in an MCQ and stuff, they're probably likely to give you all 3 features. So nail, oral leukoplakia, and abnormal pigmentation. But yeah, the most important thing is, especially from clinical side of view, is that they have organ fibrosis, like lung fibrosis and liver fibrosis, which is important because they can have quite severe complications after chemotherapy, including with these organs. Skeletal well, yeah, but they can have skeletal as well. And all of them can have skeletal problems, and they would probably have lots of others as well, but this is the ones I'm predominantly described. Now, Schwarzkopf-Diamond syndrome gives you pancreatic insufficiency. That is the more characteristic finding here. All of them can give you other all of them predisposed to all non-heme cancers as well. Like Fanconi anemia can give you, head and neck cancers are really important. So if there's a person who has had a head and neck cancer in youth and now coming with pancytopenia, this should ring alarm bells for inherited bone marrow failure syndromes. And this risk doesn't go away even after doing a transplant as well. Breast is, as I say, BRCA genes are abnormal in Fanconi, so breast and gynecological cancers are seen as well. TALL is seen very rarely if FANK-D1 gene is mutated, but that is very poor prognosis. DC can also give you head and neck cancer. Pulmonary cancer makes sense. They have pulmonary fibrosis as well, maybe liver as well. Schwarzkopf-Diamond syndrome is not strongly related with other heme cancers as the first two ones are, but they can have as well because of the the constant inflammation and things, especially in pancreatic organs, pancreatic organ. Now, key diagnostic tests are for Fanconi, chromosome breakage test, which is MMC or DEB. These are basically chemicals that are supposed to induce those interstand bridges. So basically, the chromosome that's already susceptible to these, you expose them to these agents, and you basically do a karyotyping to see how they look like, and they will have lots of breaks in them. In Hoffman's, there's a picture that you can see how they look like. So normally you wouldn't see as many breaks in a normal person, but with a person who has this problem, you would see a lot more breaks, and they've got the geneticists would have criteria, etc., the BMSs to see how much breaks are pathological. Of course, you do a genetic test. You can do genetic for either three of them. This TC, you do telomere length. And SBDS, of course, you can do gene testing, but of course, exocrine pancreatic function test can be checked as well. Now, telomere length can be low in all of them, and that's to do with all of their genomic instability and stuff, because telomere enzymes can also be affected anyway, or the other enzymes responsible for them. But in DC, characteristically, that will be less than 1% of the age, and these are checked in lymphocytes. You have to remember that, because granulocytes can be affected by the pathological process themselves. Lymphocytes can be as well, but lymphocytes do not divide as frequently as other cells. Treatments, all of them are responsive to androgens, and this is what they say. If you have been treating somebody with aplastic anemia, adult, and they have a surprisingly good response to androgens, maybe you should reconsider the diagnosis as well if inheritance has been properly excluded. Now, and they say they code various mechanisms, like they can help with telomere enzymes, or help promote. Of course, they can have direct effects on hematopoiesis and stuff like that as well, but they also apparently help telomeres health as well. And of course, LOBMT is curative from the heme side of things, but Fanconi anemia, and this is what they're likely to check you with, that you have to, cyclophosphamide, if you're using, you have to use quite low doses compared to the standard, and you avoid irradiation in Fanconi. Similarly with DC as well, they have got similar complications, because they will have higher risk of pulmonary, liver, and vascular complications because of already weak organs, so to say. And STS, you have to remember that if they are just neutropenic, GCSF can sometimes work, but pancreatic enzyme replacement nutrition support is very important. Androgens, again, LOBMT. Now, after the transplant, of course, as I say, other problems like other organ impairments, and even the cancer risk does not magically disappear, so have to be monitored for them as well. And of course, for the hematological follow-up, that's necessary as well. So anything else anything that is not good here, or I will come back to you with the genetics. Maybe I've got it wrong, but anyhow. Okay, good. Okay, so it's a way of a mnemonic here to help you remember, hopefully. You probably already know this. If you're in a certain stage in your training, you've heard about these. I read about this for so many times that you don't need to know this. But if you're starting fresh, Fanconi, PAN, and CO is the chromosomes. So you've got a fan spraying on chromosomes which are already fragile and they shatter. So chromosome breakage analysis is what you're testing for. DC is as in the DC comics are on television. So that's why the problem is with telomere enzymes, and they give you dry cracking organs, DC, dry liver, dry, basically fibrosis, is what I'm trying to say. And there's a Batman there. And Schwach-Pan-Dynon syndrome basically gives you some sticky, dull stools, which is to say the PAN is for pancreatitis, STS is for stools, and they also give you shaky ribosomes. The AI suggested that we add that as well. Okay, I said, okay, fine. But as I said previously, diamonds usually give you diamonds in the name in inherited bone suggests that maybe it's a ribosome problem and maybe it's a unicytopenia, at least in the beginning. So Schwarzman diamond is neutropenia, goes initially and goes to first pancytopenia. Diamond black fan is purely anemia usually initially and then can go to pancytopenia. Okay, good. Any questions up to here or any other observations, Yavar?
No. I think the only thing I wanted to ask is like when we describe the aplastic anemia as in terms of idiopathic, when we have, for example, if we have a patient who are worsening up from the sin and we found that the patient is SLE or Sjogren's or
Yeah.
something, do you still call it idiopathic? I mean, this question always arises with me, even in ITP, like when
Yeah.
we did H. pylori testing and they come positive for H.
Yeah.
pylori. Do you still
Yeah.
call them ITP or still call them thrombocytopenia
So
secondary
we
to?
will work through the pathway, but yeah, in clinical practice, if you suspect that this is strongly associated with a secondary process, you would call it secondary to whatever, but maybe the treatment principles would be similar to the primary thing anyway, but the additional thing would be you treat the secondary problem as well, of course. Okay, is that okay?
Yeah, thanks. Thank you.
No worries. So I've given you the management there, but there are some general principles for inherited causes. As with any heme cancer or any heme condition, your first answer would be MDT. And this is very important here. And this MDT would be from, you can list all the people that you can think of, from specialist pediatricians to specialist peds hematologists, geneticists, and support workers, and things like that. So you will have to mention all of them. It should be done at a center with expertise in management. You have to mention that in exam as well. It's obvious for us, but have to mention it. Genetic counseling you have to do for the patient in exam, including prenatal diagnosis for future pregnancies. And you have to monitor for heme cancers and clonal evolution because it lives in a spectrum, aplastic anemia, MDS, AML. Solid organ tumors, you have to surveil them for as well, depending on which inherited problem they have. And organ function is to be monitored, as I say, for lung function and for DC and pancreas for STS and things like that. And siblings and relatives can be affected as well. So you do offer them to anybody who you think might be affected, especially the first degree relatives. You should definitely offer them screening as well, with the implications of all the things that you do normally for a genetic problem like that. Okay. So that was about inherited bone marrow failure syndromes. Now coming to the rest of the things would be mainly about acquired aplastic anemia, which is more common in real life and as can come in exam easily. As is that there's no exam that's complete without aplastic anemia. And I'm focusing on the idiopathic immune version of it, which is the most common because you don't find a cause in most of them. And this is really good. The diagnostic pathway is good because it is a diagnosis of exclusion. So you literally have to exclude everything else before making a diagnosis. So first, if you've suspected that there's cytopenia, then you've done hypoplasia as with your patient in the beginning. The question rings that, is this aplastic anemia? So what you would do next is you would exclude other causes of cytopenia and hypoplasia because there are other causes that gives you hypoplasia and cytopenia other than aplastic anemia, which we will discuss. Then if you can show that, okay, this looks like aplastic anemia is not another cause of cytopenias with hypoplasia other than aplastic anemia, you see if this is inherited or acquired. If this is acquired, you try to do secondary tests, as I was mentioning, and because then you have to treat the underlying cause as well. And then lastly, you have to do this. You have to, of course, assess the severity, which you would be done in earlier stages as well. But you have to exclude any abnormal clones, which are PNH clones and coexisting cytogenetic clones. And if you look in the guideline, there's a table there and lots of different tests. But if you break it down like that, as they suggest as well, it is good to remember how to what to write in there. No surprise, there are lots of investigations. The lab tests to confirm diagnosis or secondary causes of pancytopenia and hypoplasia itself. Tests to exclude inherited bone marrow failure syndromes. Tests to detect an acquired abnormal clone. Plus tissue typing of patient family. Do not forget that. This has to be mentioned in the exam, of course, especially if they are a transplant candidate now or they may become in the future. Okay, so it starts whenever they say in exam or even in real life, and this is what we forget. If they say how would you evaluate or how would you investigate, I would personally always say I would start with the history, and I would briefly give them what to look in the history, because don't just give them history because they wouldn't know what you're asking in history. So give them pointers to say symptoms and chronicity. So how long the symptoms have been for, acquired, maybe they are shorter, inherited they are longer, and recent health, any recent viral illnesses and stuff like that. Any drug history, clearly for obvious reasons. Family history, again for obvious reasons, not only of hematological problems, but any other malignancies in young age or organ impairments in young age. Social history, so alcohol is important. For example, here. And job history is important as well, because some professions might expose them to certain chemicals and stuff or radiation that would put them at increased risk. Dietary is very important, because if again vitamins and minerals, as we discussed last time, can be a problem there. Surgical history you have to mention, because if you have had a say surgery, bariatric surgery or something like that, you're at risk for not only the usual vitamin problems, but also things like copper and things as well, which are deficient in them and can give you pancytopenia. And historical blood results, you'll have a look, of course, as well, which you would do in real life. All of these things you would do in real life, but I have to spell them out in exam, because examiner would only, if to say if it's not documented, you don't know it. Basically, that's the thing. And then examination you will mention, and you briefly mention what you're looking for. Sorry, someone's now on mute and it's very loud. Okay, thanks. Unless there was a question, of course. So examination, of course, you will look for hepatosplenomegaly, which there shouldn't be, and for signs and symptoms of any secondary cause, and for any inherited bone marrow failure syndrome. So if you mention this, you get easy marks. And then you go on to say, okay, was the laboratory tests, which are starting with the full blood count, due with peripheral blood reticulocyte. As you already said for that patient, what we didn't discuss was if they have low monocytes, then there's some particular DD that you have to exclude. Pericell leukemia, as you know, but there's also something inherited called GATA2 mutation syndromes. For example, mono-MAC, so monocytopenia, and MAC is Mycobacterium avium complex. So they have got monocytopenia and very high sensitivity to atypical mycobacterial infections. They also have lymphedema as well. So that's important to mention there. You all mentioned this. You mentioned HBF as well. That is to see for inherited bone marrow failure syndromes, because stress hematopoiesis sometimes, especially if it's going on for a long time, as it is in inherited bone marrow failure syndrome, can the bone marrow can try to compensate in as much ways as possible, and one of that is to try to make more fetal hemoglobin, thinking this will correct it. Viral studies, as you mentioned, all of these viruses. Radiology, as we said, targeted radiology. So it could basically just be a chest X-ray and ultrasound abdomen, or otherwise bone X-rays and things. Just HRCT if you're suspecting pulmonary fibrosis. Echo if you're suspecting. Echo is good because you need it for heart function anyway as well. But ultrasound abdomen is important to remember, and you have to briefly mention, okay, we're looking for kidney problems or whatever. And then bone marrow examination, as we discussed, morphology, cytogenetics, and NGS. Busy slide, but I will skim through it because we discussed that with the case. You are not supposed to see You can see a level of dyserythropoiesis in aplastic anemia, but you're not supposed to see dysplastic megakaryocytes or granulocytes in aplastic anemia. Blasts should not be up. Some other cells might appear prominent, like lymphocytes, as I mentioned. You have to have a good refine. The guideline says more than 2 centimeters. And hypocellularity can be patchy as well. Avoid tangential subcortical biopsies because subcortical marrow is hypocellular. You can see a level of focal hyperplasia of granulocytic and erythroid lineages. And you can see small lymphoid aggregates. If you see them, you have to make sure they're not clonal. They can actually be the ones driving the whole process in acquired hemolysis, but they shouldn't be clonal. If they are clonal, then you have to rule out lymphomas like Hodgkin's. You do iron stain to check for sideroblasts. Reticular stains to check for fibrosis. It should be absent, both of them. CD34 stain is for blasts. CD61 is for megakaryocytes. And that's what you do. Lastly, you would do cytogenetic fish analysis. Karyotyping is the conventional karyotyping. If it fails, which it likely does because they don't have enough stem cells, then you do fish analysis for these chromosomes as a must because it helps you see if MDS might be there. But some of them are seen in typical some of the cytogenetic abnormalities can be seen in AA as well. And these are the ones that, quote unquote, benign ones. So they don't suggest that this is a malignant process going on. So deletion 13q, trisomy 8 is okay to be seen. Big A is the mutation for PNH and others. And they may be transient, but monosomy 7 is sometimes controversial, but in children, it actually usually indicates MDS. It can be seen in adults, the aplastic anemia, but people really look hard to rule out MDS in those cases. And you also have to do as you do. So you just looked at the chromosomes on a bigger level, then you look at the genes, on a smaller level. So there are different ways to do them. Most commonly, we just employ NGS panels. It helps differentiate between MDS and AML. Some chip mutations, which especially if the patient is old, they could be seen there anyway, because the person has they're just old and they have clonal hepatopoiesis side by side. But this could be like an evolving process. So aplastic anemia could be evolving into a clonal process now. But usually present in low VAFs in idiopathic aplastic anemia. It's funny that it's interesting that the guideline mentions these two, especially ASXL1, because this is thought to be like quite an aggressive mutation usually. But anyhow, a suspicious for aggressive disease that they suggest is monosomy 7, as I said. Complex cytogenetics is almost always MDS. TP53 is always bad news, and RUNX1, as you know, is not good as well. There's an inherited syndrome as well. If you see RUNX1 mutation, you have to check germline testing anyway, because there's a platelet function, inherited platelet disorder that gives you bleeding, and platelet count can be low or normal, but a person has inherited bleeding problems and predisposition to AML and other hematological cancers. That's called RUNX1 mutation. From RUNX1 mutation. And then it's a dynamic process that says it can go into aplastic anemia can go to MDS, so watch out for clonal evolution. So you've done all of that, and you think, okay, this is just hypoplasia, and there's nothing abnormal I've found. There's no indication for MDS, AML, or other pathology. All I'm seeing is hypoplasia and low counts. So you rule out other causes for pancytopenia, hypocellular marrow. Of course, one of them is the bone marrow failure itself, acquired inherited. Lymphoma is very important to rule out because the infiltrates can be patchy. But of course, hopefully you will see this bar that you will see other parents, presentation, other examination, investigation, etc. But sometimes it can just be in the bone marrow. You have to look really hard. Anorexia nervosa is an important one. It's easily given in an exam as an MCQ. So you will have a history to tell you that, hopefully. And what they were mentioning is there's gelatinous transformation of the bone marrow. So basically gelish material, especially in the background. And there are stains that you can do specifically, like LCN blue or LCN blue, whatever you say, to confirm that this is a mucopolysaccharide gel. Importantly, in aplastic anemia, you would see that bone marrow is being replaced by fat cells. But in here, you also have loss of fat cells as well. So fat cells as well as hematopoietic cells are lost. Cat2 I've mentioned, monomac is important. PNH can sometimes give you that as well. So on its own, usually it's associated with aplastic anemia, but the PNH on its own can give you hypocellularity as well. But the erythroid expansion can be there and can be patchy, so it's difficult to exclude. So these are the causes that you have to exclude for pancytopenia and hypocellular marrow. And then is the question, okay, you've excluded that as well. Now you're looking at purely bone marrow failure or aplasia. You have to say if this is acquired or inherited. Now, of course, genetics and examination finding and things would help you, but there are some clues in history. Symptom onset can be rapid in acquired. Prior counts are usually normal. Usually no family history of hematological problems, but there might be family history of autoimmune diseases in acquired, as the reverse is true for the other ones. Preceding viral illness may be present in acquired, and associated illnesses, so other autoimmune disease, especially thyroid, is what you look for. That's why we do thyroid function tests in the beginning. One of the reasons. But in inherited, you can, of course, see other organ impairment and system abnormalities as well. So if they say in exam, as we did in the mock questions, so these are some of the questions that you, of course, check. Very obvious to see if this could be inherited or acquired. Of course, you cannot, put your money on just this and say, okay, I've got inherited or acquired. This is not 1947. We have to, and then as the NGS panels become more and more common and easy to use, etc., which they are now, any suspicion, you just do them. And you have got, for the top most common problems, Fanconi, you've got that chromosome breakage analysis, and for DC, you've got the telomerase test, so you would mention them. And this is from the BSH guideline, aplastic anemia guideline, pediatric addendum. And if you're suspecting them, you do all of the tests that I mentioned, and they suggest we do these tests as a baseline anyway, which most of the centers would do on both adults and children. And if you're suspecting some inherited immunodeficiency syndromes, then you can do B-cell leukopenia as well. And this is the most important now, clinically as well. You can check for isolated genes if you're very sure this looks like Fanconi, it's a typical Fanconi presentation. But more commonly, what you do now is NGS panels, which, as you know, are available for us in the UK. R91 is cytopenia panel, R92 is rare anemia panel, and there's a specific panel for Fanconi genes as well. So you have got pancytopenia with hypoplasia, no other cause, and you think this is acquired. Even if you don't think it's acquired, you do check for abnormal clone. PNH clones. I will go in a bit more detail about PNH in a bit. And then let's you do flow cytometry, of course. And then you show malignant clone, which is, again, not one test, but a combination of all of those tests to see if there might be a malignant clone there as well. PNH, if it is present, it can give you a hint, especially if it's present in a large percentage, that this is likely acquired, because I will explain the mechanism when we go to PNH, actually. If there is lymphocytosis or peripheral smear abnormalities, you should, LGL you have to exclude as well, because you don't want to go and treat with such a severe treatment if LGL might be the problem. Sometimes it can give you biopancytopenias. So this is all till diagnostic pathway. Any questions up till here? Are you still asleep, or still awake, or gone back to sleep?
One question I wanted to ask you from perspective.
Sorry, your line's not very clear. Sorry.
Am I audible now?
Yes, it's better now.
Yeah. So, Hassan, if I want to ask you some questions from a practical person.
So it's gone to
the
being
exam?
very bad again. Sorry, Yavar. Is that
Hello?
Yavar? I can hear you. It's very, very broken.
Yeah, I think my signal here was a bit weak. Is it clear now?
It's a bit better, yeah. Let's try one last time. Otherwise, if you can type, that would be good. But let's try one last time.
Yeah, I'll do that. So basically, from a practical point of view, when you get a question in the exam, like you had posted the question which we were supposed to answer, I mean, it gives us a lot of detail which tells us things we should not do, like B12 folate. It tells the marrow is hypocellular. So I won't look for say like I look for lymphoma and stuff, because it's already saying that the marrow is hypocellular.
Yeah.
But in the exam, should we actually write it? One is just filling the paper and telling them, okay, I know this. Other is being practical and knowing, okay, You have given me the things, I'll
Yeah.
tell you. So I just wanted to clarify that
Yeah.
point
So you're very
from the
right.
exam perspective.
You're very right. You have to model your answer as per the question. You don't just regurgitate the whole guideline and say, okay, I know all of the guideline, because you will, with each question comes like the answer sheet that the examiner is supposed to mark. They don't mark you on how nicely you've written or how poetic your answer is or whatever. They just see what they're supposed to take and they take. So in the question, for example, yeah, you're right. If you it said clearly that there is this aplastic anemia going on, and there's no indication for other things, you can say, you could just mention the ones that you think were important. But I did mention the lymphocytes were a bit prominent. You can drop a line to say, okay, they appear prominent, which they can in aplastic anemia, but I would just make sure they're not clonal or things, do some further testing and things. Of course, I didn't mention cytogenetics, or I'm giving the answers to those who haven't applied cytogenetics and genetic panel, so you would mention that, etc. as well. So, but you're right. You wouldn't, but if I said, I don't know if I said evaluate or examine or something like that, you will still say history examination. I will just do history and examination, be symptoms, and just put my hand on there as well, hand on the patient as well. It's not too difficult to do that, but don't get just focused on them and forget about answering the whole thing. So yeah, that's where we are. So you have to pick and choose what is most relevant there, and this is where the exam scale would come in. And generally, I would say if you have time, are on the side of mentioning more rather than less, of course, because obvious reasons. But yeah, might not be marked for them. But if you're suspicious, you think they are asking me to say this out loud, I would just say it out loud. Just takes a few taps. Okay, but it will be interesting to see how you attempt the question, and then I will let you know what I think for that particular question, and then we will hopefully clarify a bit more. I've got the answer
Thank
key
you.
ready for that as well.
Thank you.
Good. Now treatment is very straightforward: supportive, disease modifying, curative, plus ongoing monitoring. So this is how you would, answer that in the exam as well. Always remember the treatment does involve monitoring. Almost all the conditions you have to make a heading of monitoring, because there's marks for that. And if the patient is presented to you as unwell, you add a first heading as well, urgent management, and then you say, long-term management and things like that. Supportive is very obvious for most of us: transfusion support, antimicrobial, and psychological support. So as I said, in exam key, so in the exam, if they ask you, they will probably have a tick mark for psychological. Has he mentioned psychological support or not? So just mention these two words, and you get maybe half or a mark or something like that. So transfusion support, of course, vital. Uh, they give you targets which are the usual, as you know, but the caveat that, of course, age and lifestyle can dictate different targets. You consider matching for RH and Cal, because they're going to be transfused long term. Iron overload is important. In MDS, there's already evidence that it actually improves hematopoiesis, but here as well, they do suggest we use chelation agents or venisections after transplant, and you do monitor that with ferritin and T2 star MRIs. Platelets, prophylactically, this is important. Stable patients receiving active treatment, you keep them above 10. But if they're not on treatment, unless they don't have any bleeding, you don't give them. If they are on ATG, you suggest you have a higher threshold. And the guidelines suggest you check the platelet response as well with the first one, for example, to make sure they are actually responsive. And you don't want to rule out HLA antibodies and stuff before giving the ATG, because with ATG, the platelet requirement goes up. If there's bleeding, then you give them a individualized target. They do suggest that if the patient is very unwell with infection and is neutropenic, granulocytes can be given. But again, as an option, you have to mention that in the exam. Real life, sometimes we do use them, very rarely. But anyhow, people are not clear about his efficacy at the moment. But some are very quote unquote high believers in this. And you have to mention that you will irradiate if there's any indication for that. Now, antimicrobials, antifungal, and antibiotics, not antibiotics, for severely neutropenic patients, and prophylactic antiviral is also important. PCP, we say not usually for aplastic anemia. And psychological support is very important, actually, which we forget in real life sometimes as well. Anyhow. And this is based on the guidance. So disease modifying, LOBMT, it's got a good cure rate if it's done in young patients. And IST has IST stands for immune suppressive treatment. Sorry. So when we say IST, what we normally mean is ATG and cyclosporin. Plus minus L thrombopag. So not a standard of practice in the UK at the moment, but in US, for example, they are using this a combination of front. But anyhow, the response rate is around 70% at 6 months. So they do see some response, but that's at 6 months. It takes a long. So LOBMT actually, theoretically, if you actually do it from day 0, you would see a quicker response in the counts. But with IST, you see a response in 6 months. You don't declare a failure until 4 to 6 months actually. That's why if you need a quick count rise, then and if everything is in favor, then LOBMT is better to give you quick results. L-Thrombopag, I'll mention. There's a slide on that at the end. Guideline does mention that, but to give where it's indicated, which I'll mention, but say you have to say it's not nice approved at the moment. So if it's idiopathic, if it's non-severe, that's why important to diagnose if it's severe, non-severe. For non-severe, as you know, the only treatment option IST, and you don't treat all of the non-severe ones. You just monitor them along with their PNH clone if they have any, but it can be if indicated with the usual if they are being caused problems by the cytopenias, so bleeding, infections, and transfusion dependence, etc., or affecting the quality of life. Otherwise, you consider that. For very severe or severe, you see how old they are. If they're less than 40, and first choice is if there's available a matched sibling donor. This was also tested in the question as well. That is one of the reasons you have to make sure this is not an inherited problem, because you don't want to take a sibling as a donor who's also affected. First choice, if it's available, because of the very good response, is matched sibling donor, and it can potentially cure them. But if that's not available, then the first choice is IST with ATG and a cyclosporin plus minus L thrombopag, as I've mentioned. If that's or a little bit lower on the list is matched unrelated donor, especially if you want urgent count rise, say a person's very unwell with an infection and that's available. So second choice, you have to mention it like that, as I've said, because in real life, sometimes people would prefer match a related donor to an IST if the matched sibling donor is not available. But you have to just mention it like that. And this is not it's clear cut. They will not ask you what you would do. They would ask you what the options are, most likely, and you just have to mention with the pros and cons and say this is what you suggest. If the patient is more than 40, then you can transplant because it carries morbidity, mortality. Not to say ATG is a walk in the park. You would prefer this as first choice as per the guidance, IST with ATG and cyclosporin. But if they are, it's not concrete. If they are between 40 to 50, there's still room for transplant because of the advancements in peri-transplant care. And the guideline mentioned if there's no upper limit for ATG, at least in the exam. But if they are above 60, you really want to consider how fit they are, if they can receive ATG. The problems with ATG especially include acutely include problems like arrhythmias and allergic reactions, things that you have to make sure that the person's body is able to tolerate them. And then later down the line, of course, you can have serum sickness as well. So this is in brief the management of options of idiopathic acquired aplastic anemia. And here I just summarize that again. They can ask you the other way around. So who is ATG and cyclosporin IST indicated for as first line? So it's non-severe patients or severe patients where there's no MST, or patients who are above 40. If relapsed and refractory and ineligible for transplant, still, then second course of ATG may be indicated. Now, second course rabbit we don't use because even though it's quote unquote more potent and causes more lymphodepletion, but comes with more side effects and stuff as well, very severe infections. So we like horses better. And the second course is tricky. If the only option is they're fit enough, but not the transplant is not an option, you can try IST again, but the response rate drops. And the options to choose are rabbit versus horse. Rabbit is better in terms of response, but comes with very high significant risks. Horse CTG is milder than rabbit, but again, more likely to have complications this time if you didn't have last time, like serum sickness and stuff like that, because you've already been exposed to it once. So now the immune system might be sat there waiting for those house antibodies to come again. And lastly, monitor following. Of course, you do lifelong monitoring because relapses can occur. And PNH, you say if it's quoted as per the guidelines, so 6 monthly for 2 years and annually. Clinical review, and if they have had a stem cell transplant, you follow up in the transplant clinic for late effects so specific reasons, which is for hematological relapse and etc., clonal evolution, and also psychological counseling, and also the late and long-term effects, etc. as well. And you keep an eye on the chimerism as well to make sure they don't need anything sorting from that side of view, and their what's the word? The bone marrow is still donor, or as much as you want is a percentage is donor, the blood cells. Relapse, you assess response at least after 3 to 6 months, but you don't call them a failure at least 6 months. Anybody knows you giving ATG, so you see if you were to check their lymphocyte count the next few days, they would actually have no lymphocytes there because that's what ATG is supposed to do. So ATG is a polyclonal mixture of anti-human T cell antigen. So it will go in there, bind to the T cells and call opsonization and degradation or whatever, and T cells will disappear. But it still takes 3 to 6 months for counts to come back. Why is that? Because lymphocytes are gone. So the analogy is that it's like you're on a battlefield, you've killed the enemy soldiers or whatever, but the battleground has horribly been destroyed. So you need time to repair and regenerate that, which is the bone marrow and stuff. And hematopoietic stem cells, even if there are a few of them still there, they need time to regenerate themselves and also the appropriate environment to grow. And hopefully that will come with time. And even if a few stem cells manage to do that, they will repopulate the entire bone marrow. You do not need a lot of stem cells to repopulate the bone marrow, but it takes a long time. That's why I say transplant, quote unquote, on paper is quicker, but comes with its own problems, as you know. And of course, in the transplant clinic, you have to keep monitoring about GVHD. Is obvious. Forgot to mention. So if there is a relapse, you reconfirm the diagnosis, exclude inherited bone marrow failure syndromes if you haven't already, and exclude clonal evolution. And the options depends on what they got the first time, but ISTs, rechallenging is an option, or LOBMT, depends if they have a good donor now. But if they, again, in BMT, the options preferably would be match sibling donor or match unrelated donor. If they are not available, then alternative can be looked into, like maybe a level of a mismatched donor or haploidentical or cord blood. And these are just to mention. You don't go into too much detail, and then you're not expected to know all the detail, but you need to know that these are the options that you can do. Trials always in all the questions you have to mention, and not just for the question itself, but for real life as well. If there are trials open, you do mention them. Other options is not very good, but alemtuzumab is an option of like very, not the best, but you can use that if a person has got bad aplastic anemia, relapse, and say they have got kidney impairment. You can't use much others. You can use that as a monotherapy. Androgens again can be used, as I say, especially danazol and oxymetholone. Danazol got problems with supply in the UK, but oxymetholone is there. And if you do use them, you have to assess for side effects like hair growth in females problem. We're talking about adults, of course. For children, when you use them, you have to be cautious that it can cause excessive hair growth, which is not good at all for any child. But also you have to monitor the liver function. It can give you hepatic tumors and things like that. So you have to monitor them closely. Don't give GCSF or mycophenolate or cyclophosphamide. Other autoimmune conditions, as you know, when you go to second, third, fourth line, you will see, as in ITP and aplastic anemia, you will see MMF, cyclophosphamide, azathioprine, this and that. It doesn't work very well for this condition, unfortunately. Some special situations, so elderly, you can IST and CSA, IST. Oh, it should say ATG plus CSA. So what I mean is this. ATG plus CSA. It can give you quicker response than CSA alone. cyclosporine alone, but again, more problems. And as I say, the guidelines suggest above 60, you have to be really cautious that this is the right thing to do. Other options are to use L-Trombopag, not licensed in the first line anyway, and even the NICE appraisal has been terminated for relapsed at the moment. Androgens are an option, so not really a lot of options. Again, there is alemtuzumab can be used if renal problems are there, etc. So elderly, not a lot of options. The only good option, relatively good option, is IST if they can tolerate that. Pregnancy, again, MDT. Cyclosporine can be used during if needed. PNH considerations are important, which I will discuss briefly because the risk goes very high. L-Trombopag, so a bit about L-Trombopag. So it is approved by MHRA for SAA and VSAA, so severe and very severe aplastic anemia, but not NICE approved at the moment. And this is for adults with IST, as for the RACE trial. We'll mention that briefly. I don't mention a lot of trials, but this one I would. Elderly in the relapse setting on its own can be considered, but again, not NICE approved. Need monitoring for, so in adults, the concern is L-Trombopag, even though you link it with ITP because it makes more megakaryocytes, but actually the stem cells also have the same receptors that L-Trombopag works on, the TPO receptors. So actually it actually causes growth of all the 3 cell lines. That's why L-Trombopag. But you have to monitor because in the studies they would see clonal evolution, so you have to monitor that baseline and also every so often to make sure they're not developing an MDS or an AML going towards there, especially adults. Of course, you have to monitor LFTs as you know for L-Trombopag. In children, they tried doing the same, but didn't work very well. So children, even in America, they're not usually using that at the moment with IST, if they are going to have IST. So that's usually adults and older children, etc. And briefly, this is the RACE trial. So compared to IST alone, IST plus L-Trombopag, complete remission at 3 months was 22%, and overall response of some sort was 68%. The guideline mentions how you assess response, but if you go to the table, it's quite easy to remember that what they mean by complete remission, which is complete remission or at least partial remission. And the response was quicker with if you added L-Trombopag as well, 3 months, 8.8 months. So this is quite significant. That's all about aplastic anemia. Now I've got a few slides about PNH. If you have any questions about aplastic. Is that all clear? The PNH is very, very interesting, and it's a success story, to be honest with you, because if you see previous patients from a few years ago, the only treatment was blood transfusions, and they used to have very high mortality at young age if they were diagnosed at young age, for example, adults. And now we've got such a good treatment options, which I will briefly mention, that they live almost a normal life now, which is really good. It's a very, very rare illness, and presentations can be really, really, really non-specific. And people can present to urologists, to gastroenterologists, and they stay under them for ages. They get a diagnosis of non-specific hematuria, which actually is hemoglobinuria, or non-specific abdominal pains, or borderline diagnosis for Crohn's disease, but they actually got intra-abdominal thrombosis, metastatic thrombosis, which keeps happening on and off, and they require painkillers for that. They can present to any specialty with a thrombus in their respective organ, and they can just be managing from that point of view, not realizing the next day they're getting a thrombus in a different place. So it's very rare, but very interesting. But the good thing is it's very manageable with lots of good treatment options and growing. So definitely need to keep an eye out for that. And very common in exam, which is good because not a difficult thing. So if you got the energy, we can do something similar for what we did for aplastic anemia with some interaction. Otherwise, I could just keep narrating as I am. 40-year-old was being investigated for mild cytopenias, and he's found to have a PNH clone. I hope I've got the numbers right, but this is what the PNH clone at baseline looks like. I'll give you a minute to read that. LDH is normal. So he's got mild cytopenias. Hemolysis markers are normal, and there's no evidence he's having any hemolysis at the moment. His clone is very, very small anyway. But this is the clone in the respective cell lines, neutrophils, monocytes, red cells. And it gives you the types of cells as well, which I will mention what they mean. And what would you do now? You just had a peripheral blood.
I want to do a hemolysis screen just to sort of see what the degree of hemolysis looks like.
So there's no hemolysis at all. LDH is normal, retics are normal. Retics are normal. And heptoglobin is normal. That is negative. Urine is normal. Urine is a part of hemolysis screens. There's no hemoglobinuria or hemosiderunuria. There's none of them. Anything else I mentioned? No. Yeah, this is bilirubin's normal. Yeah, so no hemolysis. It's got very mild cytopenia but he was young, so we thought, okay, we'll just start investigating, and somebody thought, let's do a PNH clone to start with for whatever reason. Or maybe his bone marrow is cooking actually, and we got the PNH clone result before that. You would do a bone marrow biopsy as well, because if you found a PNH clone, it can hint towards aplastic or hypoplastic condition like aplastic anemia or hypoplastic MDS. PNH is very strongly associated with these two conditions. And that is because I will explain why it is that in a second. That's not anything else. What you would do now. So very mild cytopenia doesn't require treatment. You've done a bone marrow biopsy, which I won't tell you what it shows. Okay, so it's a layer of hypoplasia, but nothing else. And you've excluded all sorts of causes for that. You basically got this patient with mild cytopenias, not causing problems, and PNH clone of small size. So what you would do, you're seeing in the clinic now. You are the PNH specialist now all of a sudden. Of course, in the UK, you wouldn't see them. You would refer them. You would see them locally, but you would refer them to one of the two centers. Yeah, sorry, what was you saying?
We'll take obviously detailed history from the patient to see how the degree of the disease has been going on in the past. Has the patient had any history of thrombosis?
No
What
thrombosis. Yeah.
Was he being treated for any coagulation? His kidney functions, possibly because of the hemosiderunuria, they get renal
Yeah.
involvement as well.
Yeah, that's normal as well. So kidney
Otherwise,
function is normal, LFT is normal.
their
His
symptomatology
history was like
being pretty.
this was like a pre-op blood test for a hernia or something, which was non-related. So he's actually fit and well in himself.
I mean, otherwise, yeah, it will be just to tell the patient about the diagnosis and, as you said, to find any association with the bone marrow syndrome.
Yeah.
And otherwise, yeah, treatment, I think, is most to support you. You'll explain the diagnosis to the patient, possibly in a.
Yeah. Does he?
I'm not sure.
Yeah. So he's quite stable. Do we need to give him any treatment at the moment? He's got no warning sign, no thrombosis, no nothing. And PNH clone is very, 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 very small. 0.03%. Do we need to give him any treatment for his symptom, if his anemia, his mild cytopenias or PNH?
Do we not just monitor every 3 months to see if it's stable?
Yeah, you monitor them as per the BSH guideline. You monitor them and you can do as Sharon said. So you monitor them, yeah. So this is what you continue to do, but he disappears somewhere, and then 5 years later, he comes back, and this is what he's got now. Develops dark urine, abdominal pains in the preceding months, and dysphagia. Bloods is of course a hypothetical scenario. Bloods LDH, the lab says, I don't have a number, the sample's hemolyzed, try to take it properly next time, please. He's got marked anemia, he's got hemoglobinuria, and you repeat a PNS screen, and this is what it shows. What's happened now?
I think the severity of the disease has increased, possibly the clone has increased.
Yes, so he's got proper PNH now, as to say, proper as in classical hemolytic PNH now. The 3 variants of PNH. So he's got classical PNH now. So what would you do now? So what's the LDH thing? Hemolyzed. This is what the lab IC open eyes, it says hemolyzed. People know that.
Sorry, I didn't hear the question.
Sorry? So 5 years later, this is how he presents, and you do an LDH because you suspect his dark urine is hemoglobinuria. Abdominal pains might be thrombosis in the tummy. Dysphagia is from hemolysis causing nitric oxide consumption and smooth muscle dysfunction. You say, okay, we'll do a hemolysis screen again, and the usual full blood count, etc. You do LDH, and the lab says, sorry, I can't give you a number. The sample's hemolyzed. You haven't taken it properly. Try to have a good venesection technique next time, and then I can reattempt checking how the LDH looks like. The rest of the bloods show marked hemolysis, anemia, reticulocytosis, raised bilirubin, sky high bilirubin, or whatever. Okay, bilirubin they can't check as well because hemolyzed sample. Haptoglobin's very low. Urine is positive for red cells. So what's the LDH and hemolyzed? But then it was an ST7 who took the sample, whose only job is to take samples for 7 years. So ST7, whatever, yeah. Our experience fellow, whatever, let's say. He's now a hemolyzed sample, whatever. Very nice picture. Why is the lab saying samples hemolyzed then?
Not because of the ongoing hemolysis.
Because he is hemolyzing. That's why. And this is a very
Hemolysis.
common occurrence. And most people know about this on the call, especially those who work with me, but they're just too shy to answer. This is a common occurrence because LDH appears so high, or they think it's just samples. This is an artifact that they didn't take it right, and this is hemolyzed while taking it or whatever. But LDH is sky high because this hemolysis is sky high. And it appears so high that the lab would think, okay, there must be a problem or whatever. So that's why in PNH patients, you actually label them. This patient has got PNH. If he has ever had an LDH done with your lab, you tell me if you think the sample is hemolyzed, because that could actually mean they're hemolyzing sky high, and this is not an artifact. So that is important to remember. Okay. So what's happening now? So they developed hemolytic PNH. With all of these findings, PNH clone has taken over. So previously, only 0.03% of his total neutrophils were PNH cells. Now, 98% of his blood neutrophils are PNH cells. So you see his blood is taken over by the PNH clone. So the PNH stem cell has taken over, and the rest of the stem cells are just quietly sitting there if they're even present there. And blood is predominantly PNH now. So what would you do now? 6 monthly monitoring or something else?
He will need treatment at the moment. There is an indication for treatment. It's got marked anemia and very high LDH.
Yes, definitely. Otherwise, his hypothetical patient would curse you in their if you don't treat them now, because they can get very unwell, which they already are. So how would you treat it? Of course, in an exam, you would say A2 assessment and all of that, stabilize, and consider this, consider that. But for the PNH itself, how would you treat him? Specific, as in general management and specific management, as I've said. So we know the general.
Symptomatic to give him blood transfusion, support him to bring the hemoglobin up to a level of physiological requirement like 7.
Yeah.
7, and obviously to see if he has, if he's hemolyzing, so we'll have to target the complement pathway, which is activated in him, and give him a complement inhibitor.
Which one?
I haven't seen a patient of
No
PNH
worries.
and managed him as of yet, but there are two. There is aclusizumab and the other one which is given less frequently.
Revolusimab. Yeah, perfect. You at least that's really good. So you know the answer. That's good. This patient needs urgent, out of hours or whatever, 9 a.m. or 2 a.m. or 1 a.m. They need, as you say ATRA for APML. This patient needs anti-complement therapy there and then. Even if you have to import this from the moon, you have to give them. All hospitals are actually supposed to keep a stock, not from the moon. So you give them anti-complement therapy and do the rest side by side. But this is the first thing that goes in them. And most people I would discuss, but most people would want eculizumab to start with in this situation. because it works quickly and much more experience, etc., etc. Is the patient having intravascular hemolysis or extravascular hemolysis, by the way?
Intravascular hemolysis.
Intravascular, yes. So, and this is from complement activation, as we would discuss, and you would give him eculizumab to treat that. Okay. Anything else you would do? I mean, there were lots of other things you would do, but specifically for PNH in this patient, he's got abdominal pains. You will see what the abdominal pain is coming from, and you would do a CT scan of his tummy. You would do, portal Dopplers and things like that to see if he's got Budd-Chiari and things like that. And of course, you would give him anticoagulation as well. If you find a clot, you will give him treatment dose anticoagulation, of course, and things like that. So you have to say anticomplement therapy and anticoagulation. These are the lifelines for him, and you would do that. You do that.
Is anticoagulation given even without a clot, or I mean only if you have a clot?
So I will discuss that prophylaxis bit. Because if this is controversial, but I'll discuss it down the line. Even in a stable patient, if the clot goes above, say, not the clot, the clone goes above 50%, most people will consider that. But some guidelines will say don't. There are not a lot of guidelines for PNH, it's so rare. It's very expert opinion based, but some people will consider if they go above 50, or if they become pregnant, or if they're having an operation and things like that. And it would usually be prophylactic dosing in the absence of a clot, but you would say you do a scan and you go in prophylactic or treatment dose accordingly, okay? Because PNH is a triad of intravascular hemolysis, cytopenias, and thrombosis. Morbidity is from thrombosis and mortality is from thrombosis usually. Of course, anemia and things would be problematic as well. So anticoagulation and anticomplement therapy. So you're given that there wasn't any clot identified. With anticomplement therapy, it gets better. And 6 weeks down the line, he gets discharged. You're seeing him in the clinic now. He still continues on his eculizumab every 2 weekly or so. And now you've done repeat tests, and they're all hemolysis is gone. He's not got any symptoms that they're mentioned here. Hemolysis markers are now normal. Say, let's say 8 weeks or something. But the PNH clone, of course, is still 98% and things. So do you stop the eculizumab? Of course, no. You continue with that. And there are options to change to other treatments. Say this patient just continues on eculizumab, or they decide to change to ravulizumab, which is, as you said, is given more spread out. Either of them. Now you're seeing him, he's very well now. He's gone back to normal. He just, other than the injection that he keeps getting IV. But say 6 months, 2 years down the line, his hemoglobin was perfectly normal before that. So in the coming 2 years, his hemoglobin normalizes, everything normalizes. But 2 years later, while being on while being on C5 inhibitor, which is eculizumab or ravulizumab, now he starts getting anemic again. But there is no marker for it gets anemic again. Bilirubin goes up. It's mild anemia, but still from 150 or 140 or something, the hemoglobin now is say 100. Let's say 110. So his hemoglobin's gone down to 110. Bilirubin's gone up. LDH has gone up a little bit. Retics are up. What would you do now? He's not got any intravascular hemolysis symptoms. And the only thing that we've noticed is getting a bit tired.
Seems this is possibly because they only don't have a deficiency of complement proteins which protect the cells for the C5 complex, which is obviously inhibited by the eculizumab and the other one. They also have deficiency of protection of cell from C3 complement complex, which causes extravascular hemolysis. So that component is not taken care of by these two therapies. So he might be getting extravascular hemolysis now.
Very good. Yes. So they are getting extravascular hemolysis now, and this actually is seen more prominently when the person is on anti-complement therapy. And do not worry if you do not understand this. I will go a few slides to explain exactly that. And this is how they will flow up in a scenario. Comes in, you monitor it. Initially it's small, you monitor it, and then it goes break, and it causes problems. Then you treat it, the acute phase, then you take him in the clinic, and then intravascular hemolysis is sorted, and then comes the extravascular hemolysis, and you have to explain why it is and what you would do. So say hemoglobin continues to drop, what you would actually change it to a treatment or add in something else that targets the extravascular hemolysis as well now. And of course, you would do before that, you would do direct Coombs test. And what is it likely to show? So direct Coombs test has been normal in this scenario at baseline at 5 years. But now 2 years on 2 years on the C5 inhibitor, direct Coombs test is likely to show what?
Would it be C3 positive?
Yes, C3 positive. But you don't just say, oh, okay, this is extravascular hemolysis from PNH, you explore other causes. And what else could help you see if this is extravascular hemolysis from PNH induced complications like the C5 inhibition? It's cruel if you haven't done PNH. So basically, you would see like you see the PNH clone here, you can see a clone of red cells that is coated by C3. So you will see what's the C3 load on the red cells. So this might be 0 at the moment or whatever, but it might reach up to say 40% or something in 2 years. And that would, so C3 loading, which is the amount of C3 present on the red cells. So you can detect that by flow as well. Okay, good. Oh yeah, you used that negative and you've done all of that. So it's very interesting illness. Pathogenesis wise, it's almost always associated with bone marrow hyperplasia. This is just theoretical, but does anybody know why that is? So it's usually associated with aplastic anemia, hypoplastic MDS. Nobody knows really, but there is a suggestion that maybe everybody has PNH stem cell in them or acquires them at some stage, but they are kept silent because they are like 99% of other normal non-PNH cells and stem cells, and they just keep it under control. But if those PNH stem cells get a chance, say from acquired aplastic anemia targeting the other 99%, and this PNH clone escaping the immune attack by some reason, then that would take over, that will become more prominent and then give you PNH cells instead of those normal cells. So what happens is this is an acquired, it's not an inherited condition. So PIG-A mutation in a stem cell, there are other PIG mutations, but PIG-A is the most commonly described. PIG-A mutation in the stem cell, PIG-A stands for phosphatidyl inositol in a stem cell, gives rise to cells that arise from the stem cell that are deficient in GPI anchor. GPI anchor, I will explain what that is. So some of the proteins on the cells, on the blood cells, they are linked with GPI. So GPI is like a stand that is present on the cell membrane, and those proteins that do important jobs, they actually need that stand to stand on. So they are linked to them. So if you take the stand away, the protein that was sat on the stand of the chair of pig or was sitting on the chair of GPI anchor, if you take the chair off, they will fall off the cell as well, and then you will lose that function. So you will have loss of GPI anchored proteins. For example, these two markers, which are CD55 and 59, these normally are present on the cells, but they're sitting on a GPI anchor. What they do is they prevent complement attack on the cell. If GPI anchor is gone, these proteins are dislodged or gone, and then the complement can now attack the red cells, and this will cause intravascular hemolysis from membrane attack complex, which will give you intravascular hemolysis features. The hemolysis can be so bad, the hemoglobinuria can be so bad that you keep losing iron in your urine and it gives you iron deficiency. It will release free hemoglobin, which causes nitric oxide depletion, because free hemoglobin scavenges or whatever the word is, free nitric oxide, and that will give you smooth muscle dysfunction, because nitric oxide is required for smooth muscle relaxation. So dysphagia and some of the abdominal pain and things like that, and erectile dysfunction are from NO depletion. This is very thrombotic, along with activation of white cells and platelets from the same, because the complement proteins, the GPI linked proteins are also present on white cells and platelets, other ones, and this deficiency will lead to their activation. And when they get activated, especially the platelets, that's not good. And endothelial dysfunction will also happen. So all of this will make a very ideal scenario to form blood clots, and with the resultant blood clot causing organ damage. So this is the pathogenesis. Start with the PIG-A mutation in the stem cell, leads to a deficiency of GPI anchor, and all the proteins that needed a GPI anchor to sit on them, they are gone, and you suffer the cells suffer the consequences. Clinical presentations and when to test are interlinked. So intravascular hemolysis, you definitely test. Unexplained hemolysis, that's tagged negative, or you're giving you features like smooth muscle dysfunction. Thrombosis with unusual features or unusual sites. Cytopenia, so unusual feature that is normal thrombosis is quote unquote DVTPE. So even though it's DVTPE was such an extensive DVTPE, or out of the blue, unusual sites, of course, you would do, or if it's thrombosis or cytopenias or hemolysis, or with smooth muscle dysfunction, say, if there's evidence of bone marrow failure, you check for PNH, because PNH can give you an indication this patient has got severe aplastic anemia or something. And lots of people with aplastic anemia, I think up to 70% or something, if I'm not wrong, have a PNH clone, which might just remain small, but there is. So PNH clone is like an indirect pathway to diagnose the hypoplastic process, like aplastic anemia or AMDS. A person, there's a old person who can't have bone marrow or whatever, they're cytopenic. Maybe some people squeeze in a PNH clone to see, to do on the peripheral blood to see maybe they have a aplastic process in there. And if there's other cytopenia you can't seem to work out, might as well just do it. It's a very simple test to do, but life-changing consequences, very rare. And in your life, you would have sent thousands of them. Even one of them might not have come back positive, but you still continue to send thousands of them, because even if that one comes back positive, which is significant, then you do save life, because as I say, it's a success story, as I will mention. Okay, diagnosis. How do you diagnose them? What would you check?
Flow.
And what would it show?
Cytometry.
Sorry?
Absence of that shows
Yeah.
absence of the
Exactly.
CB mark attached.
Exactly. Perfect. Yeah. So most times when you do flow, you're looking for something extra present on the cells, but this time you're doing flow to check the absence of what's normally present. So absence or reduction of GPI-linked proteins is diagnostic of PNH. You do it in two steps. First, you do a flow to say, you use a lineage-specific GPI non-dependent marker to characterize or gate a cell, so say a white cell. So you use a marker that is not GPI linked to say, okay, these cells are white cells, and then you check on them with a GPI dependent marker to diagnose PNH. Because if you start with the, you have to know which cells exactly are, and then you check them for GPI dependent markers to diagnose or exclude PNH. There are lots of GPI linked markers. The first one is the most important, which is FLAIR, which is a bacterial toxins modified version, adding fluorescence or whatever to them. The good thing is that this binds to the GPI anchor itself. So you can detect if that's absent, patient has PNH. But the problem is you can only do that on granulocytes and monocytes only. You can't do them on red cells because they don't let the dye bind properly or something like that. There are other reasons as well. So FLAIR is only for granulocytes and monocytes. Monoclonal antibodies, so other GPI linked markers, you definitely need to remember all of them that I mentioned at least on this slide. So CD55 and 59 are for red cells. So 16 and 24, as you know, are granulocyte markers, but they are GPI linked. And monocytes, CD14 is one of the GPI links. But granulocytes and monocytes, of course, FLAIR is there as well. FLAIR is good because it's quite sensitive, because as I say, it just targets the GPI anchor itself. You test in at least 2 lineages. Nobody asked me in the question that I showed that the PNH was such a big clone in neutrophils and monocytes, but the red cells were like only 20% or something. Probably you know the answer anyway. But why was the red cell clone so small? Any suggestions?
Hemolysis.
Very good, yeah, hemolysis. And of course, they can be transfused as well. That's why the PNH cells are actually gone. That's why you can't check them in the, they're hemolyzed and gone, so they can't check them in flow. You never rely just on the red cell flow to exclude PNH. So you do it in more than 2 lineages. And as a standard in our local PNH center, we test in granulocytes, monocytes, red cells, even reticulocytes, and do C3 loading if they are on complement inhibition. And RCC clones are reported as type 1, type 2, type 3. Type 1 is normal, so they have normal expression. Type 2 has got partial loss of GPI-linked proteins. Type 3 has got complete loss. Apparently, type 2 gives you more prothrombotic tendency, but it's not 100%. Anybody can have thrombosis with PNH, and you just to know about it, basically. Okay. As you diagnose them, you monitor them, you do a bone marrow diagnosis, you monitor the hemolysis markers, you monitor the PNH clone, And lastly, most important is end organ damage. You would see that this is again all expert guidelines and practice, etc. But you see that most of the PNH patients would end up having a baseline, even if they have no problems in the tummy or whatever, they will have a baseline Doppler of the liver to make sure there is no clot there, because sometimes it can be silent, because this is how prothrombotic it is. And most of them, I mean, those who have a significant PNH clone, say above 20 to 30% at least, very small PNH clone like the one that he had at baseline, 0.03%, that's unlikely to give you any problems. And they also do an echo to make sure they haven't got any pulmonary artery pressure rise, to suggest that they might have chronic pulmonary embolism. Because if they have a pulmonary pressure rise, you do CTPs and stuff. Any suspicion of a thrombosis, you do organ directly. So they come with a headache, they will ultimately end up having a venogram or whatever. They come with a tummy ache, they will end up having Dopplers and MRIs of venograms and things, because this is very important to diagnose and treat. The cause for mortality and morbidity is thrombosis in PNH. And these are the treatment indications which you're very well aware of from the guidance, so taken from there. So, not all patients need treatment. So the clone itself, even if it's 98%, which is unlikely to not give you hemolysis, but a clone itself does not require on paper treatment unless actually the joint service says, yeah, we should do. But if there is thrombosis, you treat. If there's complications associated with the hemolysis, you treat, like pulmonary hypertension, renal failure. Pregnancy and 3 months postpartum, especially PH clone more than 20%, most people will consider it. This is what you would say in the exam. Hemolytic PNH would also, so LDH has to be more than 1.5 times the upper limit of normal in anemia, or if the joint service says otherwise, because they are much more experienced with this. An exceptional case is, again, as agreed by the PNH joint, MDT happens not every Friday, but I think happens at least once a month on a Friday. So, this is the complement pathway, which I'm sure I didn't need to show you guys, because you already can draw it. Everybody can draw it. It's like such an easy thing to do. But anyhow, what happens is that C5 activation happens by whatever way, leads to the formation of MAC, which is membrane attack complex, which goes onto the cell and causes lysis. And treatment is, you give eculizumab, which is the first one, life-saving, and given every 2 weekly, then revolizumab, and now there's a new one, crovalimab. It blocks the C5. So what happens if you block this? All the previous complement proteins can accumulate, especially C3, which is of importance, because as you remember from my heart talk, so C3 will coat the cells, and coated red cells will love to be, this is opsonization, and the opsonized cells will love to be cleared by the spleen. So the problem in PNH on its own mainly is the dangerous intravascular hemolysis from here. So you block that by eculizumab. But if you keep a person long, or the other C5 inhibitors, if you keep a person on long enough on them, ultimately they will get C3 loading, and a proportion of those patients who have C3 loading will start developing extravascular hemolysis now, which is not as serious as intravascular hemolysis, but can be a problem. That's why there are other ways to treat that. Pegcetacoplan is a subcutaneous treatment which targets C3 itself. So if you target C3, then you treat intravascular and extravascular hemolysis, because you never have C5 anyway either. So this targets both intravascular and extravascular hemolysis. This is funny because even though they're targeting this, looks like they're targeting the same pathway, but factor B, when it's inhibited, because it's more important, and D is actually a coenzyme for B. Iptacopan causes both intravascular and extravascular hemolysis prevention, because it ultimately doesn't lead to C3 formation. But D1 predominantly targets extravascular hemolysis only. So these are the treatment options: eculizumab, revolizumab, crovalimab. All three are C5 inhibitors. I've listed them roughly in the order they were, made or designed or whatever. Because these are C5 inhibitors, they only target intravascular hemolysis. Pegcetacoplan is easy to know. C3 inhibitor targets both. Iptacopan targets B. B is the big one. So, and how do you remember B? Iptacopan. Yes. So in Arabic there is no P. So if you ask any Arabic colleague to name this, they would say ibtacopan. They won't say iptacopan. So that's how I remember it, because some of my Arabic colleagues would say ibtacopan. So that's fine. B is the big one, so it targets both. And D is an add-on. D for add-on. Yep. So basically, D only targets extravascular. You cannot use the danicopan on its own at all, because it only targets extravascular hemolysis. The killing problem in PNH is intravascular. So you always add it on to a C5 inhibitor. At the moment, it's added on to one of these two. And this gives you how they're given. This was life-saving, but problem is IV every 2 weeks is a big thing to ask. And this is IV every 8 weeks, less a big thing to ask. But still, these two have got, eculizumab has the longest data. So very good. That's why in emergencies, most people will rely on that. Eculizumab next in line has got very good data as well, given every 8 weeks. These are the newer ones. Iptacopan is very, very, very good as well. And so is danicopan. But this is interesting because it's oral and targets both of them. So a person can practically be on just on a tablet and then takes care of everything. And danicopan gives you the luxury that you can have the intravascular hemolysis sorted and be relaxed about that from revelizumab. But if you have extravascular hemolysis, okay, you can target that with the tablet. Problem with tablets is you have diarrhea, vomiting, you get to take tablets and things like that. In PNH, it's not paroxysmal. The hemolysis is present all the time. So if you miss a dose, you get the hemolysis reappearing. So you cannot afford to miss a dose. So that's why it's you always have to have an intravascular hemolysis backbone, and basically drug. And danicopan, you have to remember, is an add-on. This is commonly checked in exam MCQs. The danicopan can't be used. Can be checked in exam MCQs. Shouldn't be used as a standalone treatment. This is how it works, as I said. So C5 inhibitors would cause C3 loading, and that's when you start seeing opsonization and extravascular hemolysis. So treatment supportive, anticoagulation. Yeah, prophylaxis. Some people would say don't use it, but some would use it in specific scenarios if the bleeding is if the thrombosis risk is high, bleeding risk is low, and the PNH clone is significant. Some people say above 30%, but especially above 50%, they would use a prophylactic anticoagulation. And this is to say when they are not having any indication to have anti-complement therapy, but just the prophylaxis with this. If they have a clot, you give treatment dose anticoagulation. Most people it will be individualized, but at least 6 months if they are established on anticoagulation is important. And you have to attribute the thrombus to a PNH as well, not to something else. This is the very important vaccinations and antibody prophylaxis, because all of them are inhibiting complement, which are otherwise going to help you fight infections, especially encapsulated. Most common being these three. And Neisseria can give you meningitis. That's why any patient who comes on them with a headache, you have to exclude, as a matter of priority, meningitis, and you give them broad spectrum antibiotics on the A&E till you're excluded it. Because this is the mortality, this is the main problem from complement inhibition. Otherwise, they live with pretty decent life. And vaccination against these three immunogens, of course, as well. So pregnancy, you only use eculizumab here in the UK at the moment, as far as it stands. And even if they are not requiring treatment, otherwise, you saw the indication from the research guideline, it is used. And periop, some people would consider a bit of so if they are already on anticomplement, you try to do the surgery just after the dose instead of in the last few days of them, leading up to a dose, so that they've got good anticomplement there. Breakthrough hemolysis can be from pharmacokinetics. So you've given a dose, say now, of revelizumab, and maybe in 7th week or something, they start getting pharmacokinetic. So they start losing the effect. So that's why you have to monitor their blood initially quite closely. Or if they are symptomatic in the last week, the person comes to you and they say, just before my dose, I get some symptoms coming back. So you suspect that. Can be pharmacodynamic, which is you see a complement surge, even though they are on complement inhibition, but you sort of see a complement surge from infection, surgery, pregnancy, or vaccines. Then, that can give you pharmacodynamic hemolysis breakthrough. That is why if you do give them vaccination, even the patient that we discussed, they come to you, you will give them anticomplement therapy, you give them thrombosis treatment. You would also give them vaccination, but you give them on the day instead of before that. Because if you give before that, going to make the hemolysis worse with the complement enhancement or amplification or whatever. Lastly, exacerbation of extravascular hemolysis, which is common because C5, that is how they work, C5 inhibitors, they are ultimately going to give you C3 loading. So how would you diagnose is that positivity and C3 coating on the red cells, PNH flow. These are some of the resources I used. And that is all. Any questions? About PNH or anything
Thank you
else?
so much.
Hussein,
That was very helpful. Thank you so much, Hassan.
No, that's fine. I again couldn't stop it to 1 hour, but anyhow.
That's fine. Can I ask,
Hussein,
since this was my first session, so can I ask if you're going to do it every Sunday or is it Saturday usually?
I will try to do one of these 2 days. It just depends on how I can do it best, because say for Friday I was on call, so I didn't want to
Okay.
leave it to last time, because if I'm awake all night, then I won't be able to do 9 a.m. session. But some people
No,
also
that's fine.
requested for Sunday, to be honest, for other
Hmm.
reasons. So I will see how it goes week by week, and I'll let you know in the
Okay.
WhatsApp group.
No, that's fine as long as I know it's variable. Thank you so much, Hassan.
No worries, thank you.
Hussein, sorry, I just got a question.
Mhm.
So at what percentage you would consider like this patient's got like significant BNH clone?
So usually they say more than symptoms are unlikely to happen under 20%, but it's variable as it with anything in medicine. So above 50% definitely is, but 20 to 50% is like a window where you don't know about. But some people can have symptoms at a lower clone as well, say 10% or something. But that's very, that is why with, the guideline also it says, if the PNH team agrees that this is PNH symptom, you exclude everything else, you would treat them. But in exam, they are unlikely to give, and they shouldn't give you thingy that's unclear. So they will give you 98% clone, hopefully, or 99% in the exam. Hope that helps.
So in the after testing for the BNH clone, and when you classify them as type 1, type 2, type 3, is that something reported on the when you get the results? Does they go
Yes.
like yeah?
Yeah, well, let me show you. So yeah, you should see, this is how they show you. As I showed you in the case. So this is how it comes up. They can even show a reticulocyte clone as well, but this is how they come up. What you have to look for is mainly the granulocyte or the monocyte clone more than the erythrocyte as well is important. But as I say, there's caveats with the erythrocytes. They can all be hemolyzed and disappeared. And you're only seeing 20% here, for example. But there was definitely a lot more, but they're actually hemolyzed and they're not checkable on when you took the patient sample. Or a person can have had blood transfusion. So again, the transfused blood is not PNH blood, so they will have normal PNH protein expression.
Yeah.
Yeah. Okay. Good. So if no further questions, I will stop the recording and sharing. If you have any questions after the recording stops, that's fine as well. Give me a second.
Thank you for watching. Stay tuned for more.